Okay, sir. Thank you, sir. Good evening, everyone. So today I'm Dr. Sunil. I'm my moderator, Dr. Nalinikanta. I'm going to present. I'm going to now discuss on the topic updates on the newborn resuscitation after the newborn resuscitation program 2021 guidelines. So before heading to the proper discussion, I would like to discuss what all things changed from the NRP 7th edition 2015 to NRP 8th edition in 2021. We might be already familiar with this one. And in the first thing that changed was in the pre-birth question, the 4 pre-birth questions, it was initially the gestational age, amniotic fluid, whether clear or mecanostained, and additional risk factors and the how many babies. The how many babies question has been changed, and it has been changed to adding a umbilical cord management plan. So in the second one, the initial steps of resuscitation were reordered. Initially, it was warm and maintaining a temperature, then positioning the airway, clearing secretion if needed. Drying and stimulating was the last part of the initial steps of resuscitation. In the NRP 8th edition, the warm, dry, and stimulate had given importance. The warming, drying, stimulate, then position of the airway, suctioning if needed was being recommended. In the third change was the cardiac monitoring, the electronic cardiac monitor was recommended in the earlier in the algorithm. In NLP 7th edition, the electronic cardiac monitor was preferred method for the assessing the heart rate during cardiac compression. That was in the later part of the algorithm. Whereas in the 8th edition, it was been recommended when an alternate airway becomes necessary. The cardiac monitor is to be recommended for the accurate assessment of the heart rate. The next changes that happened was the IV flush following the epinephrine via giving intraventricular intraosseous. Initially, in the 7th edition, the 0.5 to 1 ml was recommended. In the NRP 8th edition, it was 3 ml normal saline push to be given, followed by the IV or epinephrine dosage. And the dosage of the IV epinephrine or endotracheal dose, IV epinephrine or endotracheal epinephrine, has been simplified in the 8th edition. Initially, it was 0.01 mg to 0.03 mg for the IV, and it has been absolute given as a 0.02 mg per kg. And in the for the endotracheal dose of the adrenaline, 0.05 to 0.1 mg per kg was given in the initially 7th edition, and it has been absolute given absolute dosage given 0.1 mg per kg, that's equal to 1 ml per kg. And the last change that has been changed on the expanded time frame for the stopping or cessation of the resuscitative efforts. In the 7th edition, after the confirmed absence of the heart rate, the 10 minutes of resuscitation of the following resuscitation, there is no confirmed heart rate, then it was reasonable to stop resuscitation efforts. Well, it is recommended. In the 8th edition, the timeline for the resuscitation for 20 minutes has been extended. So today I'm going to talk about the few topics which has been revealed post NRP 2021 in the last 2 to 3 years. So first one will be the umbilical cord management in the preterm neonates, umbilical cord management in the term and late preterm neonates, temperature management in late preterm neonates of less than 34 weeks, ventilator support devices, TPs versus self-inflating bag, and supraglottic airways for the neonatal resuscitation. Umbilical cord management at the birth. Umbilical cord management topic has been an area of robust investigation and this umbilical cord management guidelines has been clearly recommended in the last NRP 2021, but the better understanding of the preterm, late preterm, and term infants, there have been further systemic review has been conducted. In the NRP 8th edition, 8th edition, for the preterm infants who do not require resuscitation at birth, it is reasonable to delay the cord clamping for longer than 30 seconds. And in a term infant who do not require resuscitation at birth, it may be reasonable to delay the cord clamping for longer than 30 seconds. These two are the vigorous babies who do not require resuscitation. The delayed cord clamping was recommended and it was reasonable to follow. And for those babies or infants who are requiring resuscitation, that is term and preterm infants, there was insufficient evidence to recommend the early cord clamping versus delayed cord clamping. And in the less than 28-week infants, the cord milking was not recommended and that. So there's a pictorial graph telling there's been many guidelines came and they're given for various timeline for the delaying cord clamping, which is starting from the 0 seconds to 300 seconds, 5 minutes. Has been various platforms, various guidelines has been given. In the recent one, AHA 2020, they recommended for more than 30 seconds. And NRP 2021, 30 to 60 seconds. And European was giving more than 60 seconds was being recommended. In a recent American Academic Pediatrics and American Heart Association journal recommended that delayed cord clamping versus early cord clamping in the less than 34 weeker, there has been 16 acids has been conducted. In that, there was the delayed cord clamping showed possible improvement in the survival to discharge infants when receiving the delayed cord clamping compared to the early cord clamping. Out of 16 RCTs, the 6 studies showed that infants receiving the delayed cord clamping had the decreased inotropic use in the first 24 hours. And those infants receiving the delayed cord clamping had a improved hematologic indices in the first 24 hours. And they also received the lesser number of red cell transfusion during the admission. And when the entire cord clamping in the preterm of less 28 to 34 weeks was compared with the early cord clamping, among the 11 trials, infant receiving intact cord milking had a higher hematologic index in the 24 hours. In the 5 trials, they showed the fever inotropic is in 24 hours. And infants with the 28 to 32 weeks, there is no benefit or harm of the intact cord milking for the severe IVH has been there. In a preterm infants, when the intact cord clamping was compared with the delayed cord clamping, there is a single trial it was showing there is no increased IVH when we are comparing with the umbilical cord milking and delayed cord clamping. In a single study of 182 infants of 23 to 28 week gestation, which are not requiring resuscitation, the umbilical intact cord clamping was associated with severe IVH when we compare with the delayed cord clamping. This is a recent data that has been published in the Lancet Journal, which was published in November 2023. It has been telling that deferred cord clamping has been compared with the immediate cord clamping as a high evidence for there's decreased mortality at discharge. Decreased mortality at the discharge. And there is no difference in the admissions. And there has been telling that no differences, and the increased hemoglobin increased hemoglobin level at the admission. There's decreased need for blood transfusion, and there's decreased hypothermic episodes when the delayed cord clamping was compared with the immediate cord clamping. And when the umbilical cord clamping was compared with the immediate cord clamping, there has been decreased need for blood transfusion has been notified. There's a forest chart is comparing with the umbilical cord milking with 15 seconds, 15 seconds to 45 seconds, medium 45 seconds to 120 seconds, and longer than 120 seconds. This has been compared with the umbilical cord milking, and always showing the better improved or discharge. And in the when they compared comparison with the umbilical cord clamping, delayed cord clamping with the intact milking, and there has been IVH has been more with umbilical cord milking in less than 28 weeks. When the intact cord milking is compared with the early cord clamping in the term and late preterm infants, those term and infants, one RCT was including those 1,730 of non-vigorous newborn infants. There is no difference in the primary outcome when we compare intact cord milking with earlier. However, there was no difference in the primary outcome when we compared the intact cord milking in the term neonates in a non-vigorous newborn. There has been differences in the secondary outcome, that is increased hemoglobin levels, reduced need for cardiorespiratory support. When this is a diagrammatic view summarizing the umbilical cord milking in the non-vigorous term and near-term infants. There has been decreased requirement of the respiratory support at the admission. There has been decreased HIE cases in non-vigorous babies when umbilical cord milking was been done, and that before discharge was less. So in the latest modification, those preterm newborn infants with 28 to 38 weeks who do not require resuscitation and in whom the delayed cord clamping cannot be performed, intact cord milking may be a reasonable practice. For those term and late preterm infants and they are non-vigorous, intact cord milking may be reasonable when we are comparing with the earlier cord clamping. Coming to the next topic, the temperature management at the birth for preterm neonates. In the prior recommendation of the NRP 2021, there's among the newly born preterm infants of less than 32 weeks is being which are born in the delivery room with in radiant warmer. The combination of interventions like environmental temperature of 23 to 25 degrees Celsius and using the thermal mattress, plastic bag or wrap, heating, humidification of the gases, skin to skin care, and radiant warmer has been well given. But this was given for the less than 32 weeks. There has been further studies has been done post NRP 2021, including even gestation of less than 34 weeks. There's a recent public article published in the Resuscitation Journal 2023, a systemic review. In that they took up less than 34 weaker as a preterm infants, and the intervention with increased room temperature more than 23 degrees Celsius, using thermal mattress, plastic bag wrap, heating and humidification of the gases used for resuscitation, and radiant warmer without servo control, and then they compared with the drying alone or with the use of plastic bag or wrap. The critical outcome was survival to hospital discharge, and other outcomes were having a the babies having normothermia, moderate hypothermia, cold stress, having a hyperthermia. So there's in the systemic review, when the increased room temperature was more than 23 degrees Celsius, has been compared with other room temperatures in a less than 34 weeker. When the operating room temperature was 20 degrees Celsius, 23 degrees Celsius, there is no benefit or harm was being given for the any outcome. When the room temperature of more than 24 to 26 degrees Celsius has been compared with the lower 20 to 20 degrees Celsius, there's been increased body temperature on the admission. There's been reduced moderate hypothermia has been there. And when the thermal mattress has been used in a less than 34 weeker, 34 weeker, the survival, there's 19 more, more survival, 19 more infants were survived when we 19 more infants per 1,000 survived more when we use a thermal mattress when comparing with the no thermal mattress. And the babies having normothermia at the admission, there's 363 babies per 1,000 were less when compared to the babies when we are not using thermal mattress. And the intervention was the using of the plastic bags or wraps in the infants born with less than 34 weeks. So when the plastic bag were used, 41 more infants were survived per 1,000 in comparing without using the plastic bag. And the babies with 238 babies per 1,000 were more normothermic in comparing with the not using the plastic bag. And the heating and humidification gases was used for resuscitation comparing with the not using the no heating or humidified gases for the infants less than 34 weeks. There is no differences when comparing with the survival, but the number of babies admitting to NICU in normothermic babies were more when comparing without the heating and humidification, and the number of IVH cases were less. Number of moderate hypothermia cases were low. So ILCOT 2023 suggests that in a preterm neonates less than 34 weeker, the room temperature of 23 degrees Celsius was better to maintain the normal temperature, and it suggests that it is reasonable to consider addition of thermal mattress, but the risk of hyperthermia was to be considered, and the use of plastic bag or wrap to maintain normal temperature has been suggested to follow, and use of head covering to maintain normal temperature has been suggested, and the heated or humidified gases for respiratory support can be used when the resources are permitting in a less than 34 weeks. Coming to the next hot topic, the ventilator support interface. When they come, there were many studies compare the TP resuscitation with the self-inflated bag. In the previous NRP 2021, there's given a clear-cut idea on when to use the positive pressure ventilation, how how much pressure to be used, how much inspirated time should be used. The clear-cut idea was given, but there's not much details or recommendation on the interface for giving the positive pressure ventilation. And post NRP 2021, there has been many studies regarding that. In a meta-analysis of 4 RCTs, they found that TP resuscitation reduced the duration of positive pressure ventilation, and there is decreased risk of bronchopulmonary dysplasia. And this TP resuscitation, especially in a preterm neonates, there has been decreased number of bronchopulmonary dysplasia has been observed. This systemic review of the still that all the trials, when they use the TP resuscitation, favoring the in hospital, whenever the TP resuscitation has been used, the in-hospital mortality was less when TP resuscitation was used, and the BPD cases were less when the TP resuscitation was used. And the third one, the duration of positive pressure ventilation when was also less when the TP resuscitation was used. The further going to data, the TP resuscitation when compared with the self-inflicting bags, in-hospitality mortality were less, the grades of IVH were low, the BPD were low. So in the recent 2023 AHA AAP focused update has recommended that it can be beneficial to use the TP resuscitator instead of a self-inflating bag with or without a positive pressure, a PEEP valve, for administering the positive pressure ventilation in newborn infants. Whereas this in the NRP 2021, the device for interface or the positive pressure ventilation was not been mentioned. The next topic that has been exclusively studied was the supraglottic airway for the newborn resuscitation. There has been understanding of the potential of the supraglottic airway in improving the outcome of the babies requiring resuscitation. So the ILCOR Neonatal Life Support Task Force aimed at comparing the supraglottic airway with the face mask as initial device for the administering positive pressure ventilation immediately after birth, and to see the probability of improving of the of survival with the positive pressure ventilation when given with the supraglottic airway. So the NLS task force reviewed 5 RCTs, 1 quasi-RCTs for this, and they took infants of more than 34 weeks as a gestation, and they intervened with the subpropaglottic airway or laryngeal mask airway, comparing with the face mask. With the critical outcome of chest compression, or the epinephrine usage when the SGA is used, or survival to hospital discharge, and the neurodevelopmental impairment at the 18 or more than 18 months of age. And the other outcomes were the failure to improve with the device, and tracheal intubation during the initial resuscitation, time to reach the heart rate there, and time to cessation of the positive pressure ventilation, soft tissue injury. In the data, we can see whenever the supraglottic airway has been used, there have been 105 babies per 1,000 infants. Lesser babies had a failure to improve when the SGA has been used, and 41 out of 1,000 babies lesser babies required endotracheal intubation when the LMA has been used. And there is nothing much difference when in comparing with without the LMA for the face mask if you took the chest compression. And the duration of the posterior pressure ventilation has been less when they used SGA, and admission to NICU also lesser, almost 25 to 1,000 infants, and the SGA has been used. But there is no difference for the outcomes of ear leak, that is pneumothorax, and soft tissue injuries, and survival to hospital discharges. So the ILCOR NLS life support recommended that when the resources and the trainings permit, it is suggested that a supraglottic airway may be used in place of a face mask in a newborn infants of more than 34 weeks gestation, receiving the posterior pressure ventilation during resuscitation immediately after birth. And EAP focused update also suggested that it may be reasonable to use a supraglottic airway as the primary interface to administer posterior pressure ventilation instead of a face mask for the newborn infants delivered at more than 34 weeks. But NRP 2021, the LMA was not considered as a primary interface for giving the posterior pressure ventilation. And the topic is an evolving concept, the femoral occlusions during the neonatal cardiac respirator support, in neonatal cardiopulmonary resuscitation, improving the outcome. The Satyan Lakshmanasan team, they were doing an animal study on the cardiopulmonary resuscitation. They did an animal study on the lambs during requirement of cardiopulmonary resuscitation. Occlusion at the femoral levels with a goal that the improving the blood flow to the heart, improving the blood flow to the brain was the ultimate goal by occluding the femorals, and seeing the outcome in that study. Almost the 70% of the fetal lambs has been had a return of spontaneous circulation was been noted. The same data, when the femoral occlusion group they done, in that they had a better systolic BP, they had a better diastolic BP, and the coronary blood flow and the carotid blood flow were good. And there is return of spontaneous circulation in the 70% of the fetal lambs, and the FeNO doses were less. So it's an evolving concept, and it's happening in the animal studies. And to sir.
Sunil, are you concluding your messages, all the messages?
Yes, sir. Not so. Umbilical. So
any conclusion slide is available? All the messages which you want to give today?
No, sir, it's missing. No. No, sir. It's been. So take home message in a mildly preterm infants who is having a low risk of IVH. the delayed cord clamping has been preferred when compared with the intact cord clamp, intercord clamping. And milking may be a reasonable option if a delayed clamping is not feasible. Those preterm infants which are having high risk of IVH, intercord milking, not recommended in a less than 28 weeker, but the 28 to 34 weeker who are having non-vigorous babies and in whom we cannot do delayed cord clamping, intercord milking has been suggested. And the temperature part, the recent guidelines, recent studies has been suggesting to use thermal mattresses for the more than 34 weeker. The plastic bags, plastic hats has been suggesting to use for the more than 34 weeker for the normal temperature management. And the heated humidified gases, those babies requiring during resuscitation, even for the 34 weeker. And the positive pressure ventilation, those devices, the TP resuscitation has been suggested to use, recommended to use, rather than using a self-inflating bag for giving the positive pressure ventilation. And the supraglottic airway for the babies who as a primary interface to give the positive pressure ventilation has been recommended.
So any question, if any of the audience can ask, just please request them, all of them to ask any question, so you can take any of the questions. So probably the audience can ask any question in the chat box, or can directly ask also questions to you. So are you aware of one question from my side? When you are reading the meta-analysis, are you aware of a duration of a cord clamping? Any new evidence generated recently? What duration? You have raised a concern starting from 15 seconds to till 300 seconds. So various recommendations are existing.
Yes.
But do you know what is the current evidence which is the most beneficial about the critical outcome survivability in preterm population?
So 30 seconds to 60 seconds.
No, that's the existing guideline says more than 30 seconds, at least 30 to 60 seconds.
Yes.
But in recent evidence from the same, what I was referring, the Lancet meta-analysis review, individual patient data, which you quoted, now significantly advocating among all the preterm babies to go for delayed cord clamping, which reduces 30% of mortality, which published in 2023 November. Same day only, another meta-analysis published from the same group of authors. What they proposed, they compared below 45 seconds to
Yes.
120 seconds, 120 seconds, more than 120 seconds. So 120 seconds equivalent to 2 minutes. That gave the best result if you will compare the survivability. Okay.
Yes.
So that evidence also till now 30 to 60 seconds might in future we can see a recommendation for a longer waiting period, because this is one of the robust meta-analysis among all the meta-analysis published before about the duration, and duration towards 120 seconds is giving the best result.
Yes, sir.
So evidence slowly might change. Tom baby, previously also they were recommending little higher minutes might be more useful rather than just 60 seconds. Same thing about the preterm population. This too, I will request all the audience till now who are listening at least to go for the evidence for the Lancet 2023 November 14th and 15th, and Lancet, two of the very important and exciting meta-analysis which involves the individual patient data. It is not the meta-analysis from the studies only. They've invited all the authors to share the data of individual patients. From their two important conclusions they derived. In that conclusion, if we will say it below 32-week, delayed cord clamping significantly improves outcome in the form of one of the very critical outcome is mortality, which reduces 30% mortality in the preterm population, which is a very significant benefit. And coming to duration, the second paper is highlighted. If deferred to 120 seconds, that's the best benefit in comparison to 60 seconds. These are probably two the take-home message from two of the meta-analysis in Lancet published last month only. And if you have properly highlighted about the temperature care, about the umbilical cord management in non-vigorous babies and the preterm population, considering intact cord milking in beyond 28 weeks, which the whenever the DCC is not feasible, they cannot wait. The non-vigorous babies can do above 28 weeks, because below 28 weeks again it is 4 times increased IVH. The IVH incidence is 4 times higher in the cord milking groups. So if we are doing a delayed cord clamping is the best, not able to do, not feasible, intact cord milking can be offered as an alternative in 28 weeks onwards. That's the new additional sentence from the NRP guideline, which published in Pediatrics Journal last month. So these 3 or 4 very important publications, I will request all audience to go through. Lancet to meta-analysis, one of the guideline publication about focus guideline in pediatrics, and ILCOR meta-analysis about less than 34 weeks temperature practice. When previous recommendation all were limiting the recommendation to 32 weeks, now the new recommendation might come, including another 2 weeks. It is extending to 34 weeks below all the temperature practices standard recommendation. Better to adopt up to 34 weeks. That's a few of the practice change probably all we can adopt. And any questions I am asking? We got a question about the femoral occlusion study. The femoral occlusion study, any side effects in the lower limbs? The femoral occlusion study is a lamb study, is animal study. Till now, clinical practice not started. But that's a idea about increasing the preload to the heart. And so in the increasing the return of circulation, augmenting the return of circulation when we are managing with the PPB, we are going chest compression, we are giving adrenaline. That's extra improvement in the preload to the heart, might improve the return of the animal study. Till now, no clinical study. And the side effects, if we clinical studies we use for prolonged period, it might be affecting some way, but a brief period of few seconds occlusion, what side effects role, unless we do a clinical study, will be difficult to comment. Hopefully, you passed a message, new message, Sunil. Previously, 2021, all the standard recommendations we are aware, but by this focus guideline, which are the few of the practices highlighted recently, we all should be aware. And the important Lancet publication this month only, November month 2023, about cord clamping, cord delayed cord clamping, or cord management. We should go through the right message. Probably we pass in the presentation. With this, you can take any of the questions. Probably I'm not seeing any question in the box. So thank you, Sunil. And thank you all the audience.